in Critical Care Professional Community webinar. My name is Archer Martin, and today I will be serving as moderator for this event, which we've entitled An International Update on Perioperative Lung Transplantation Management. The content and speakers were selected by my fellow co-chairs, who are members of the Anesthesiology and Critical Care Professional Community Leadership Council. We have representatives from all areas of the ISHLT's 4 main interdisciplinary networks: advanced heart failure and transplantation, advanced lung failure and transplantation, mechanical circulatory support, and pulmonary vascular disease. If you're not familiar with ISHLT, we are the world's premier multidisciplinary society looking at international collaboration between colleagues of multiple specialties, all focused on taking care of patients with end-stage heart and lung disease. If you want to learn more about how to join, visit our website at ishlt.org. It's in the spirit of this collaboration that we put on our webinar today. Not only do we have a non-anesthesiology and critical care colleague presenting on behalf of the ISHLT, Dr. Sandra Lindstedt from Sweden, we also have colleagues from around the world representing the respective top societies within cardiothoracic transplantation anesthesia. From the Society of Cardiovascular Anesthesiologists, we have Dr. Brandy Bodiger. For the Society for the Advancement of Transplant Anesthesia, we have Dr. Teresa Gelzinis. And from the European Association of Cardiothoracic Anesthesiology and Intensive Care, we have Dr. Arnie Nyrink. After these recorded lectures, we're going to have a live Q&A session. We look forward to your enjoyment of this webinar, as well as the questions and answers to follow. Thank you very much. Welcome to the International...
A cardiac anesthesiologist.
Apologies for the technical difficulties.
Hospital in Sweden, and my talk will be about a publication, a study that we just published, and it's about using a cytokine absorption during ex vivo lung perfusion and post-transplantation in the attempt to both increase the donor lungs, but also to reduce primary graft dysfunction. And I hope you will enjoy the talk. So the major obstacles in organ transplantation is the imbalance between the demand and the supply of donor organs, and that results on death on the waiting list. So you could say that lung transplantation faces 2 unresolved challenges that lead to high waitlist mortality and low graft survival. Inadequate availability of transplanted donor lungs due to high rates of lung injury in donors and high rates of primary graft dysfunction, an early cause of mortality in recipient, well, that is 2 major problems. And today we don't really have a good solution or treatment for that, for either of the conditions. So due to organ shortage, attempts are being made to find ways to restore the function in lungs discarded for transplantation. And prior healthy donor lungs, they can be damaged in the donor. They could be damaged due to infection, due to neurogenic edema, to gastric aspiration and ischemia. So the method of EVLP, you all know, it consists of supporting the lungs outside the body through a ventilation and perfusion while maintaining sterility, humidity, and graft temperature in a closed environment. And we use the system that was developed by here in the Lund group. So one would ask, is there really a role for cytokines in transplantation? And is there a role for actually try to reduce those? Well, it might be. Well, this figure shows a representation of the time course from the donor through the postoperative period, including ex vivo lung perfusion, and demonstrate that proteins and cytokines, they do play a role, an important role, all across lung transplantation. So it might be good to try to target those. Cytokine has also been associated with prognosis and early graft function during ex vivo lung perfusion and also post-transplantation, and especially IL-1 beta, IL-6, and IL-8 can be used to differ a good from a bad graft. So given the role of cytokines in transplant biology, it seems to exist some form of justification for trying to use the cytokine absorption within the context of transplantation. So this is nothing new. Cytokine absorption during human kidney ex vivo perfusion has shown to reduce delayed graft function. And it's been also used in a case series of heart transplantation, and then the patient has been found to have a decreased use of inotropic support and better graft function post-transplantation. This is a photo of Sarah Hoscott, and she's a pioneer when it comes to cytokine absorption within kidney perfusion. So cytokine absorption has also been tried before to be placed in line with ex vivo lung perfusion with a hope to increase the tolerance of prolonged ischemic time. So donor lungs with prolonged ischemic time treated with cytokine absorption, they showed actually better lung compliance and oxygenation compared to control animals. So in the present study, we set up to explore if cytokine absorption could improve damaged donor lungs and improve outcome after transplantation. So in order to discuss our application of the cytokine absorption in this study, I will first give you an overview of the experimental model. So we use LPS derived from E. coli to induce acute lung injury. And once the lung injury is established, we put the lungs on EVLP. After 4 hours of EVLP, we transplant the left lung into a healthy recipient, and then the recipient is monitored throughout a few days. On the third day, we do a right pneumectomy, and after the right pneumectomy, we follow the animal in additional 4 hours. So in the present study, we wanted to explore if EVLP alone, followed by cytokine absorption post-transplantation, could regenerate RDS donor lungs, or if we would add cytokine absorption during EVLP and also post-transplantation would have a better effect. So we wanted to compare this to a control group that went through lung injury, EVLP, and transplantation, but did not get any cytokine absorption at all. So we had 3 groups. 1, the non-treated. 2, what we called one step, that only got cytokine absorption treatment once after transplantation, and then the 2-step treated group that got once during EVLP and then also once post-transplantation. So we ensured that we had a model with acute lung injury using X-ray and histology. Cytokine measurement in plasma and in bile fluid showed significant increase in cytokines after establishment of acute lung injury, as you can see here in the figure of histology and X-ray before and after induction of lung injury and RDS. After establishment of our lung injury and RDS, we then compared the treated with the non-treated lungs during EVLP. So when we connected them to EVLP, they still all had an RDS. And the treated lungs, they showed a significant increase in oxygen capacity during the time course, and they actually reached acceptable levels for transplantation. While the not treated lungs, they did not really reach that point, and the not treated one also experienced a significant decrease in compliance and higher pressure. But there were no difference between the 2 groups when we compared them. So the lungs were treated with or without cytokine absorption during these 4 hours of EVLP. And the slide shows a gross morphology of the treated lungs on the top and the not treated lungs at the bottom throughout the 4 hours period. So cytokines in plasma was followed then every hour in the EVLP, and they showed a general low levels in treated compared to the not treated lungs. And in especially IL-1 beta was actually the only one that was significant between the group. But IL-1 beta showed a significant difference between the 2 groups, and that was in favor for the treated groups. And if you recall, from my previous slide, that IL-1 beta could be used as a marker to detect a bad or a bad from a good graft. And the same pattern of this IL-1 beta and the rest of the cytokines was also found in bowel fluid after the end of EVLP. So the images here are the H&E histology, and they showed a resolution of the acute lung injury RDS changes in the treated lungs, while the not treated lungs still had a severe lung injury and was also reflected in the lung scoring. So the treated lungs showed a sort of a restoration and repair of the lung damage during EVLP. But if you compare this to the histology taken after establishment of lung injury, well, then both treated and not treated lungs actually became better histology-wise. That was also reflected in the lung scoring. We then looked to compare the treated and the not treated recipients following left lung transplantation over the course of 3 days. In total, we had 3 groups. Just to remind you, we had the group who received cytokine absorption during EVLP and post-transplantation, the 2 steps. And we had a 1-step group who received cytokine absorption post-transplantation. And when we gave it post-transplantation, we gave it for 12 hours. And then we had one that just went through the whole without any treatment with cytokine absorption. So the setup of post-transplantation hemofiltration with cytokine absorption is seen here in the movie. And as you can see, it's connected to a dialysis catheter on the neck of the animal. So if we look at the cytokines in plasma and in bowel fluid post-transplantation, we can see a generally lower levels of cytokines post-transplantation, and that implies a reduction of inflammatory state during lung transplantation and follow-up in the treated animals compared to the not treated animals. And the same pattern regarding the cytokines was also seen in the bowel fluid, but there were no significant difference here between the animals. So in this figure, you see the PF ratio during the whole time course of the experiment, and you see the PVR and the definition of the primary graft dysfunction afterwards. So at the top, you can see the PF ratio. In the start there, you can see the PF ratio before we take out the native left lung, and then thereafter you see the ratio where after the transplantation and over the time course. As you can see here, there's no difference during the first day, but at the end of the second day, the 2-step treated group start to become different from the other 2 groups, and especially after pneumoectomy, right pneumoectomy. Then you can see that the not treated group, they do quite poorly, while the 1-step group goes sort of in the middle, and the absolutely best result we get from the 2-step treated group. That was also reflected in the PVR, but also when we did an X-ray and looked at primary graft dysfunction post-transplantation. All of the not treated animals had primary graft dysfunction, either classified as PGD3 or 2, while in the 1-step group we had 2 with and 2 without PGD, and in the 2-step treated group, only 1 patient or 1 recipient had a PGD, while the rest did not. So in regards to H&E histology, the not treated animals, they showed massive infiltration of inflammatory cell and loss of airspace, and also deposit of hyaline membranes, where the histology for the animals who we call them 1-step, they showed a little bit better, still a little bit infiltration of inflammatory cells. But then if you look at the 2-step treated groups, that shows absolutely best results. In the bottom here, you also see the tunnel staining, and you can see the apoptotic cells. And there was significant amount of apoptotic cells in the non-treated group, while a little less in the 1-step and significantly less in the 2-step treated group. And both the changes in the histology in the H&E and the tunnel staining was confirmed by the blinded scoring. So we had a few details in the outcome. So one animal in the not treated group and one animal in the treated group, they developed severe septicemia post-transplantation. And despite advanced ICU treatment with massive support of inotropic support and fluid, the not treated animal died 9 hours post-transplantation, while the treated one actually did survive. One animal in the one-step treated group developed a severe tachyarrhythmia post-transplantation, and we were a little bit scared to put in to start the cytokine absorption because the animal was so unstable. But then we did it, and then after 1 hour of cytokine absorption, he actually had a sinus rhythm again. It's just one animal. It could be a coincidence, of course, but it can also be due to reduction of the cytokine levels. So overall, the treated animals required significantly less inotropic support than the not treated animals. So in one recipient in the treated group, the graft developed dramatic pulmonary edema after 2 hours of EVLP, and we can draw up to 1.2 liters of fluid, as you can see here, the drainage from the trachea during the EVLP. And measurements were taken during transplantation to actually fit this enlarged graft into the chest. But on the 3rd day of post-transplantation, you see the same lung here in the figure, and it worked actually fine, good ABG and good X-ray without any primary graft dysfunction. So the result lead us to the following conclusion that cytokine absorption reduces primary graft dysfunction, and it lowers the lung injury score and also increased the oxygenation. Overall, it actually decreased the use of inotropic support, and we do think that cytokine absorption significantly actually improved the outcome in this setup. So are there any open questions still? Well, we don't know. Is it good to reduce all cytokines? And if we go on using this in transplanted patient, would it also result in a reduction in drugs perhaps that we want in transplanted patient as immunosuppression, glucocorticoids and antibiotics? And then how do we support that? And what is the optimal duration of the treatment? So these are all open questions and to think about when going into using this in clinical settings. So I would like to thank you for listening to this talk. I hope you all enjoyed the presentation, and don't hesitate to contact me for any questions. Thank you.
Hi, I'm Brandy Bodiger. I'm one of the cardiac anesthesiologists at Duke, and I'm an associate professor of anesthesiology. I'm also the medical director of transplant quality at Duke Transplant Center, and I want to introduce the topic of the role of anesthesiologists in perioperative blood management and lung transplantation. I want to really thank the SCA and the ISHLT for the invitation to speak at this webinar. I don't have any disclosures related to this topic, but I do participate in an advisory board for CSL Behring in PGD and lung transplant. The learning objectives for today's session are to review the definitions of bleeding and the implications of transfusion in the perioperative period for transplant recipients. I'd also like to relay successful blood conservation strategies in this patient population and summarize the anesthesiologist's role in blood management and lung transplantation, and really any surgery that we undergo. So to start with, what does it mean to be bleeding during a lung transplant? What are the definitions that are published in the literature around this? So the definitions of bleeding that are most newly published, actually in the last 24 months or so, are the NHLBI guidelines, which outline bleeding as defined as, that's again a composite, but it's totals the allogeneic blood products needed for the first 5 days. And it also is able to measure the 5-point ordinal score for thrombosis and bleeding. And so these have been recommended for the uses of definition in future publications and grant funding in the sphere of cardiac surgery. It may be widely applicable to lung transplantation. Historically, I think we've really focused on the definition of massive transfusion as being more than 10 units of red blood cells in 24 hours. This spans across various surgical populations and is a pretty well understood metric. The universal definition of bleeding for cardiac surgery has been published on the right, and that was by Dyke et al. In 2013. The nice part about this definition is that it is a composite, so it does include other factors that imply bleeding, like delayed chest closure, re-exploration, chest tube output, and factor use, as well as your blood product usage. And so therefore, I think it's a pretty comprehensive look at the way patients bleed, in particularly lung transplantation. Remember here, we're not really measuring EBL because often we're using self-salvage. So this is a pretty ideal way to quantify bleeding. On number 4, organ-specific considerations. So in the lung transplantation literature, particularly registry data and outcomes data, greater than 1 liter of red blood cells has been identified as a marker or risk for severe primary graft dysfunction or ARDS. So those are kind of the numbers and definitions floating around out there. What are the recipient risk factors for bleeding and transfusion? Well, firstly, there's age, preoperative anemia in the presence of that, thrombocytopenia or platelet function, the presence of critical illness or indwelling mechanical circulatory support, small body surface area, female gender, non-elective surgery or non-isolated surgery. Certainly the more urgent the patient and the less opportunity for optimization, the more significant things like bleeding can be. Redo surgery is also quite problematic, as well as adhesions in the chest, which make the tissue damage and subsequent bleeding even greater. Anticoagulant use or known coagulopathy are also factors to consider as you're coming into a surgery, and you may be able to switch to an anticoagulant that's easily reversible in those settings. What are the risk factors for bleeding for a procedural standpoint? Includes having more surgery, so a bilateral surgery over a unilateral procedure. The approach also seems to matter, where described publications on minimally invasive approaches have less bleeding than a maximally invasive approach that's shown on the right. The cold clamshell incision. The previous chest surgery we talked about, but if you're re-entering damaged territory or even where there's previous cardiac surgery, it can be a precarious situation. Mechanical circulatory support. The more cannulation sites, the more types of pumps involved and conversions involved, episodes of hemodilution, dilution of clotting factors and platelets, and just again, kind of blood contacting foreign surfaces can result in more bleeding. There's also the amount of heparin seems to matter with each of these. So the level of heparinization is under fire, and we'll get back to that in subsequent slides. What are transfusion-related outcomes of interest? So in cardiac surgery, it's pretty well established that transfusion adversely affects your survival. It causes a significant morbidity, including lung injury, ARDS, trolley, TACU. It also has been associated with AKI and renal failure, with infection, with venous thromboembolism, with adverse neurologic outcome, and overall a poor recovery profile, increased length of stay. In lung transplantation, which is really special because it's a lung transplantation population, there's graft dysfunction as a primary quality indicator that's adversely affected by transfusion. Overall, reduced graft survival and an increased association with ECMO dependency and tracheostomy. It also, especially in the preoperative arena, implies sensitization. So it's more difficult for a recipient on the wait list who's being transfused to potentially find a match and can result in wait list mortality. Pretty nice study that came out of some of the UNOS data around that and SRTR. So what I didn't mention is that transfusion in the donor also has adverse effects. So what are some successful blood conservation strategies in this patient population? What can we do? I think the correct answer is that it is modifiable potentially in this transplantation. And even though there's a narrow window of opportunity, I think that there's things that can be done to make things improved. So checking out the patient in advance of the surgery, I think anesthesiologists certainly have a role there. We can evaluate patients, understand if there's room for any sort of hemoglobin optimization or factor improvement in the interim between workup and surgery. Anticoagulant use, again, if they're actively anticoagulated, we can potentially help guide the therapy based on what reversal agents are available during the perioperative period. What algorithm use has shown us in cardiac surgery and is, I think, directly applicable to this population is that any algorithm use allows for teams to set targets, communicate well about what's an appropriate target for that patient and what therapies are going to be available for use. And that in itself is very, very helpful, both in the OR and in the ICU. Antifibrinolytics, aprotinin has been historically shown to reduce bleeding in this population. No longer available in the United States, unfortunately. So things like TXA and Amicar can be explored, particularly in patients who require MCS. Factor concentrate use is also supported, particularly in the Markson et al. Document that's just been published around anesthesia guidelines, that factor 7A, prothrombin complex concentrates, and fibrinogen concentrates, if they're available, are a great alternative to a large volume FFP transfusion. So going back a little bit to optimization, again, if we're involved in the upfront process, we have the potential to help identify hematologic abnormalities, thrombocytopenia, leukopenia, anemia. And if there's substantially increased risk, like a active bleeding diathesis or severe bone marrow dysfunction, we would probably want to maybe avoid surgery completely. And so that's a team discussion, obviously, and you're going to have patients that may have some special considerations here, but overall, this is an advisory not to proceed with lung transplantation based on the 2021 guidelines. One of the blood conservation strategies that we would normally apply are acute normovolemic hemodilution in patients that have appropriate hemoglobin and platelet counts. We would be able to apply that technology potentially to a lung transplant patient. Cell saver is a very routine part of our care in our cardiac surgical area, and also shown to spare transfusions. Surgical maneuvers that can be, again, routinely applied: argon beam, electrocauterization, and harmonic scalpel. There's also adjuvant medications that we can apply in advance of surgery, including iron therapy and erythropoietin, where even single doses in, again, cardiac surgical population have been shown to have some benefit. So what anticoagulant use, how more heparin has sort of been associated with more bleeding. It's also usually an association with increased level of support by mechanical circulatory support. So a bypass circuit will require more heparin than, say, an ECMO circuit or doing an off-pump procedure. But essentially, the discussion around this is, and probably the next steps in the research are to look at whether a heparin-free lung transplantation is possible. And so there have been some case descriptions around this, and miniaturized ECMO circuits have been proposed as another alternative. So I think this is coming, but I don't think we're quite there yet, at least not in our group. For algorithm use, this is something, again, very well established in cardiac surgery. What I'm showing you now is what's been published in lung transplant surgery. So folks have in Australia published this very well in patients that were performed on cardiopulmonary bypass, that a ROTEM guided algorithm with set targets and set therapies have produced a reduction in costs in blood product use and overall an improvement in their transfusion practice. They haven't shown changes in reoperation or mortality, but that doesn't subtract from the helpfulness of this algorithm implementation. In our group, we published a algorithm back in 2018 and in 2017, sorry, in cardiac surgery that we've been able to basically edit a bit and apply in lung transplant surgery. And so that's kind of shown what we're using here, but there's no magic to those targets. It's just what our teams have agreed upon and how we've identified to transfuse and support patients that are having bleeding during lung transplant. I think it's really useful for new team members. It's really helpful for trainees and really for surgeons to know what you're actively doing to treat the bleeding, particularly after the pump run or after the ECMO run. And when we applied that to our group, we saw a reduction in red blood cell transfusion that was sustained not just in the 6 months that I'm showing you on the top left, but over 12 months. And we saw an overall reduction in the percentage of patients that met the criteria for massive transfusion. So we consider that a win, albeit this was a win that we had before the ECMO era. So we're going to restudy this and understand how we're doing now. Factor concentrate use also recommended in the Markson et al. Document, but essentially has been supported in several studies over the last few years. So factor 7A has been shown to reduce bleeding in patients that are kind of uncontrolled situations or maybe used in advance of other therapies, or PCCs have been used. So I'm showing those two pictures of commonly used medications on the right. And in the middle is Profil 9 or our 3-factor concentrate. And on the far right is Kcentra or a 4-factor concentrate. Again, alternatives to FFP or fresh frozen plasma. So do explore these within your institutions. What's the availability of them? What's the process around obtaining them? Things like fibrinogen concentrate are also available, but there's been as you know, with COVID, lots of shortages to deal with. So it's always worth exploring the availability and the cost of the drug. So what's the summary? Our transplant surgical patients, no surprise, lung transplant patients are increasingly older, sicker, and more complicated. Bleeding and transfusion in lung transplant is very common. And there's, I think, ways that we can consider as group. And the ISHLT is a great group to do this in, how we can predict transfusion, how can we reduce unnecessary transfusions whenever it's possible. And I guess the bigger picture is, what can the anesthesiologist do for perioperative blood management? We are always prepared. That is our primary job. Our job is to be involved, hopefully, in the upfront process, to prepare resources for these patients, to have honest discussions with the multidisciplinary team about the risk of these patients, what resources we think they're going to need, work through with the transfusion team, any barriers and particularly shortages have been encountered over the years. And so how do we work through that? Can we do this case safely? Do we have what it takes to take care of this patient? And then lastly, our job, I think, is to participate in studying our own outcomes in the transplant space and to develop tools and processes to improve how we're doing. So I thank you very much for your time and attention. I hope that everybody enjoyed this, and I look forward to your questions and seeing you all at ISHLT. Thanks.
Good afternoon. I would like to thank the organizing committee for inviting me to this very important webinar. My topic today is extracorporeal lung support in lung transplantation. I have no disclosures. In this brief talk, I'm going to discuss the indications and types of mechanical circulatory support, compare the studies looking at mechanical circulatory support to no mechanical circulatory support in lung transplantation, and review the recently published American Association of Thoracic Surgeon guidelines. Preoperatively, mechanical circulatory support can be used as a bridge to transplant in those patients who are hypoxic and hemodynamically unstable. This will allow prehabilitation to occur. According to the ISHLT, appropriate candidates are young, with single organ dysfunction and good rehabilitation potential. Contraindications include septic shock, multi-organ system dysfunction, heparin-induced thrombocytopenia, obesity, severe peripheral vascular disease, advanced age, and irreversible neurologic and neuromuscular disease. Strategies depend on the etiology of the dysfunction, on whether it's primarily respiratory or cardiorespiratory. Intraoperative indications include routine use, to provide hemodynamic stability during cardiac manipulation, especially during implantation of the left lung, to control reperfusion by diverting cardiac output away from the lung and by controlling PA pressures. It allows for protective ventilation and reduces ischemia reperfusion injury and primary graft dysfunction. Other indications include the use in high-risk patients, like those in pulmonary hypertension with right heart failure, and those on ECMO as a bridge to transplant, and as a rescue intraoperatively for hypoxia, hypercarbia, and hemodynamic instability. Postoperative indications include refractory hypoxia, elevated PA pressures, inadequate graft function, and hemodynamic instability, especially right ventricular failure. Postoperative ECMO can be a continuation of intraoperative ECMO or can be initiated in the ICU. The advantages of postoperative ECMO are that it allows for protective ventilation, it treats pulmonary edema due to left ventricular diastolic dysfunction by allowing controlled filling and LV recovery. It also prevents acute increases in venous pressure, reducing reperfusion injury that can cause PGD. Recommendations for prophylactic postoperative ECMO include pulmonary hypertension, questionable graft function, a PF ratio of greater than 100, a mean PA, mean systolic pressure ratio of less than 2/3 after lung implantation, lobar transplant, and interstitial lung disease with donor size discrepancy. The different types of mechanical support in lung transplantation include mechanical ventilation, pumpless extracorporeal lung assist devices, ECMO, Oxy-RVAD, and bypass. There are no randomized controlled trials performed to validate what the best strategy is. The most common percutaneous extracorporeal lung assist device is the Novolung. This device is a hollow fiber membrane oxygenator that has been used as a bridge to transplanted lung candidates. It lies between mechanical ventilation and ECMO. Blood flows through this device via an arteriovenous shunt that requires a gradient of at least 60 millimeters of mercury. For hypercapnic respiratory failure, a FEM-FEM configuration is used, and to unload the right ventricle in patients with pulmonary hypertension, a PA to LA configuration is needed. This device is effective at removing CO2 because of its high solubility. The Novolung requires lower flow rates and smaller cannulas than ECMO, which may protect the femoral vessels. It allows for protective ventilation, and since it only oxygenates about 1/5 of the total cardiac output, ECMO is necessary for severe hypoxia or hemodynamic instability. It increases cardiac workload and may induce limb ischemia. There are 4 configurations of ECMO that are going to be discussed in this lecture. The first is veno-veno ECMO, where deoxygenated blood is drained from the femoral vein and infused into the internal jugular vein, where a dual-stage cannula is used. A dual-stage cannula drains the SVC and IVC, and blood return is through the right atrium. There is no effect on cardiac function, and the indications include hypercapnic, hypoxic respiratory failure, and pulmonary hypertension, where it can increase RV preload, reduce RV afterload, and improves hematosis. It is the most common bridge to transplant. VA ECMO provides hemodynamic and respiratory support and can either be central, which is the right atrium to the aorta, and peripheral, where the femoral vessels are used. It is the most commonly used intraoperative mechanical circulatory support device. VAV is a mixture of VV and VA ECMO. A third cannula is added when standard ECMO fails. This occurs in patients on VV ECMO who develop heart failure and require an arterial cannula, and those on VA ECMO who develop north-south syndrome and upper body hypoxia who require an internal jugular venous cannula. It provides hemodynamic and respiratory support where the venous drainage occurs through the femoral venous cannula and the blood return is via the aortic and the internal jugular cannulas, providing oxygenated blood to the cerebral and coronary vessels. VV ECMO is required when there's insufficient venous drainage and reduced ECMO flow due to either small cannulas or small vessels. Other indications include hemolysis and right to left intracardiac shunting. VVA ECMO requires 2 drainage cannulas, both femoral and IJ, and 1 return cannula. The additional cannula can provide up to 1 liter per minute of flow and it's been shown to reduce right atrial, systolic, and mean PA pressures. The oxy-RVAD is another bridge transplant option as an alternative to VAV ECMO. It consists of an RVAD with an oxygenator using VV ECMO. It is implanted either using a femoral PA configuration, where the reinfusion cannula is placed into the main PA, requiring a mini thoracotomy, and the drainage cannula is inserted into the left femoral vein. An alternative cannulation is using the Protect dual stage cannula. The CentuMag and Tandem Heart RVADs are used depending on how much flow the patient requires. These patients typically have interstitial lung disease. In our institution, we have used the Protect cannula in our oxy RVADs. On the left is a view of the cannula. On the upper right is a fluoroscopic and lower right echo view of the cannula. The advantages of the oxy-RVAD is that it prevents right ventricular distension, it preserves transpulmonary blood flow, and it prevents peripheral arterial cannulation complications. There are fewer thromboembolic complications than with VA ECMO, and the PA cannula can be used as a drain during lung transplant. And without a femoral cannula, rehabilitation is easier. Complications and disadvantages include pulmonary congestion due to the increase in pulmonary blood flow, infection, and increase in PA pressures, necessitating a reduced flow in patients with pulmonary hypertension, and bleeding. So far, there have only been small retrospective studies with few patients, so its place in lung transplantation is still being elucidated. So how does active support affect outcomes in lung transplant patients? This study is from the Vienna group, who performed a retrospective study on outcomes in lung transplant patients for those who received VA ECMO to those who didn't. Their patients were placed into 3 groups. The first with no support, then VA ECMO, then extended VA ECMO, which means they had ECMO in the ICU. They studied 582 patients, where 116 had no support, 343 were in the VA ECMO group, and 123 were in the extended ECMO group. All donor lungs received ex vivo perfusion before they implanted, and the primary outcome was 1-year survival. In their initial analysis, they found the patients who received VA ECMO had higher survival than those who had no intraoperative support. But after propensity matching, there was no difference between the 2 groups, suggesting that VA ECMO and no support produced similar outcomes. The rate of severe PGD or grade 3 PGD was similar also. Laura and his colleagues formed the Extracorporeal Lung Support and Lung Transplant Registry. They performed an international multi-center retrospective study of double lung transplants performed in 10 high-volume centers, which were defined as centers that performed greater than 40 lung transplants per year. They studied 852 patients over a 4-year period and evaluated outcomes between the use of no support, ECMO, and bypass, with the primary outcome being severe PGD, which was defined as PGD grade 3 after 36 to 72 hours. So compared to patients undergoing bypass, patients who had no support had a lower incidence of PGD3, reintubation, tracheostomy, the need for postoperative ECMO, death before discharge, shorter postoperative ICU stays, and there is no difference in 1-year survival. But their primary outcome of PGD grade 3 was the highest in the bypass group, then in the ECMO group, and the least amount of PGD3 was seen in the no support group. These findings were confirmed in a retrospective study by my institution comparing no support, VA ECMO, and bypass in 557 patients. They reported that the patients with no support had the least transfusion requirement. Those with no support and VA ECMO had less need for dialysis and reduction in atrial fibrillation, DVT, airway dehiscence, and hepatic dysfunction. The no support group had the lowest incidence of PGD, followed by the VA ECMO group, and then the bypass group, and there was no difference in 1-year survival. This suggests that there may be a small increase in severe PGD in VA ECMO patients, but that overall survival is not affected. In patients with stable hemodynamics and respiratory failure, VV ECMO is the preferred bridge to transplantation. Periodic right ventricular evaluation should be performed to assess the need for alternative support. Aggressive rehabilitation should occur, and femoral cannulation is not a contraindication to rehabilitation. Mechanical ventilation can be used as a bridge when deconditioning can be avoided. And in patients with isolated hypercapnic respiratory failure, pumpless extracorporeal devices are an effective bridging strategy. In patients with preoperative cardiopulmonary failure, VA ECMO is an option in patients with end-stage pulmonary hypertension with RV dysfunction. Both femoral and subclavian arterial cannulation sites can be considered for bridging. With combined cardiopulmonary failure, VA-V ECMO should be considered to prevent differential upper body hypoxia with fem-fem cannulation. In patients with pre-existing moderate to high secondary pulmonary hypertension, lung transplantation should be performed using mechanical circulatory support. The proposed cutoff for intolerance to clamping is a systolic PA pressure of greater than 50. Planned mechanical circulatory support for controlled reperfusion of the graft might reduce the risk of PGD, and the optimal reperfusion time is 30 minutes. Frequent non-emergent use of mechanical circulatory support promotes standardization of the technique and can reduce the incidence of cannulation complications. The need for mechanical circulatory support does not exclude the use of sternal sparing approaches. The routine use of intraoperative VA ECMO does not increase the likelihood of temporary chest closure or unplanned re-exploration for bleeding. The preferred mechanical circulatory support is VA ECMO, and central cannulation is preferred over peripheral. Low or no heparin approaches should be used in patients with significant adhesions and impaired coagulation. A bolus of 2,000 to 5,000 units should be administered at cannulation to obtain an ACT of between 160 and 250 seconds, or an APTT of 1 to 2 times control, and the use of heparin-coated cannulas is recommended. In patients with bridge to transplant VV ECMO, an intraoperative switch to VA ECMO is preferred, and bypass is recommended for lung transplants combined with intracardiac repairs. With the development of primary graft dysfunction, ECMO should be maintained until lung function recovers. ECMO can be maintained regardless of the cannulation approach, and prophylactic post-lung transplant ECMO may be indicated in pulmonary hypertension to reduce the risk of PGD. Patients who are on bridge to transplant ECMO should not automatically be maintained on ECMO after transplant, and early weaning from ECMO may avoid complications. ECMO is recommended immediately after lung transplantation in patients with severe cardiopulmonary instability. Peripheral cannulation is preferred over central cannulation. Early ECMO is recommended in patients with clinical signs of severe PGD within the first 6 to 12 hours. Delaying ECMO for more than 48 hours is associated with worse outcomes. In patients with post-transplant PGD with respiratory failure and stable hemodynamics, VV ECMO is recommended. In patients on mechanical support for severe post-transplant PGD with no improvement in 2 weeks, ECMO as a bridge to retransplantation is not recommended. TEE is recommended in patients with severe post-lung transplant PGD and refractory hypotension. This is to exclude other causes of graft edema and/or hypoxia. This includes left ventricular diastolic dysfunction in the setting of pulmonary hypertension, right heart dysfunction, intracardiac shunts, and anastomotic pulmonary vein stenosis or thrombosis. Thank you for your attention.
side, but I'm also highly involved in donor care and donor selection, which means as anesthesiologists, we really work throughout the line of patients that are potential donors, become deceased donors, work in the field of preservation. Good morning, good afternoon, or good evening from wherever you follow this webinar. My name is Arjen Nering. I'm a transplant anesthesiologist and also a donor advocate working at University Hospitals in Leuven in Belgium. And I would like to thank the professional community and the society for organizing this webinar. I was invited to give a lecture on the role of anesthesiologists in lung transplantation ethics. Well, I would like to disclose that, as I already pointed out, I'm a lung transplant anesthesiologist dealing with the recipient side, but I'm also highly involved in donor care and donor selection, which means as anesthesiologists, the line of patients that are potential donors, become deceased donors, work in the field of preservation, especially in normothermic regional perfusion, also in ex vivo lung perfusion, and then also dealing with recipients and recipient selection. For this webinar, I would like to focus on the phases before we are involved with the recipients, because I think this is highly involved in an ethical debate, especially these days for anesthesiologists. And as an anesthesiologist, I'm always concerned about how we define the donor and how we comply with the donor rule. And we have shifted a lot in the last era to a more and more medical definition of that and of a donor, but we have a bit forgotten that there are many aspects of defining a donor and a dead donor, which are also ethical and societal. This is especially true when we are dealing with donation after circulatory death or DCD organ donation. And worldwide, we know that a lot of donors are DCD organ donors, which means that these are donors that are really dependent on life support on an intensive care setting, but where further therapy is futile and where we decide to interrupt and to withdraw life support in a very controlled setting. We observe when circulatory arrest occurs, we declare them dead, and then they are procured for organ transplantation. Actually, the fact that we see a lot of dry runs reported in DCD organ donation, ranging from very low to very high percentages, and that we also see a large variability in the utilization rate of DCD organ donors, is, in my opinion, directly related to a lot of ethical aspects dealing with this kind of donors. And that's what I would like to point out more during this lecture. We should acknowledge that defining death is a historical, very complex thing. We have seen a lot of definitions shifting throughout the time when we look at defining death. It was in the beginning very simple, based on intuitive traditions, absence of life, but now we have come to a more pathophysiological understanding of death. And it's an ongoing debate in time during each era when and how to define death. I do not want to plea for security coffins as pointed out here in this slide, but however, this slide really points out my point that we should be very careful and we should acknowledge that defining death is surrounded by a lot of uncertainties and also surrounded by a lot of debate in every time and throughout history. Even if you look at defining death by neurological criteria, the so-called brain death and brain death donors, we have even seen there a lot of discussion, a lot of criticism in the beginning from, as example here, Guy Alexander, one of the founders of the principles of brain death. It was highly criticized, and now these days we have clearly accepted that brain death as a very clear definition of defining death in a donor. One of the problems with defining death in organ donation, and especially in DCD organ donation, is the definition of death defined by the Uniform Definition of Death Act, which states that an individual who has sustained either irreversible cessation of circulatory respiratory functions or irreversible cessation of all functions of the entire brain, including brainstem, is dead. We should acknowledge that this definition is applied in a very early period, and it has actually been originated or developed in an era where there were not so many supported functions in ICU care as these days. But we, from the transplant community, we have a kind of over-interpreted this definition as there are two kinds of death. We have dichotomized death by circulatory death and or brain death. However, death is a unitary state. There's only one type of death, and death is a one-way ticket. You can never come back from death. So this I will take into my presentation furthermore that by defining and dichotomizing that, we have installed some of the issues, some of the problems dealing with organ donation. As pointed out, death is actually only one definition. It's irreversible loss of the capacities of consciousness, breathing, and circulation. We can use the neurological criteria or circulatory criteria to define that, but it's the same death. We could even use somatic criteria, but however, in the field of organ transplantation, this is out of scope and non-useful, of course. And brain death, as already pointed out, has evolved in a long period of time, and they have put a lot of effort in trying to uniform the definition of brain death. We have this World Brain Death Project where they want to go to a more holistic definition of that, and they have put a lot of time and effort in that to have a more biological, philosophical, and societal deficiencies of brainstem death criteria. And even there, they're still debating, is it brainstem death, is it whole brain death, or is it higher brain death based on consciousness definitions? Why should we be concerned, and why is the ethical debate so hot these days in DCD organ donation? This is a very complex timeline, but actually it illustrates that when we're dealing with DCD organ donation, we shift from a patient at the left side here of the panel towards a donor which is deceased at the right side of the panel. All the aspects of autonomy, beneficence, and non-maleficence and justice, they all shift from a patient perspective to a deceased donor perspective, and even farther on to a recipient perspective. In a controlled DCD organ donor, which is the most commonly used DCD organ donor, we stop the therapy, the life-supporting therapy in controlled settings, as you pointed out by here, and we wait until circulatory arrest occurs. After that, we wait for a certain amount of time, which is referred to as a no-touch period, before we can declare death. I would like to question you. Are we really sure how to define circulatory death? If you look at the pathophysiological point of view, we should even wait until perfusion pressure is lower than 17 millimeters of mercury. However, we use surrogates. We use pulsatility. We use mean pressures as surrogates to define circulatory arrest in these patients. And this has been mainly the focus of healthcare professionals in the last decades. And which is really important, as declaring the death in a DCD organ setting is a very conditional situation. As referred to by the Definition of Death Act, there they say that the death should be irreversible. The loss of function should be irreversible. However, when we deal with a DCD organ donor, the death is not irreversible. It's a permanent, the death is irreversible, but the situation is permanent, which means that after the no-touch period, which is meant to exclude autoresuscitation, we accept that we can declare patients dead based on the permanence principle, because we do not interfere with the process. And this is a good principle, it's a good condition, and in most of the countries, it's a well-accepted practice, and also worldwide. But the declaration of death in this situation is conditioned, as already pointed out, which means that, of course, by using the term permanent, we do not comply with the biological concept of death, which would be irreversible biopsychosocial disintegration, but that's okay, because permanent might not comply with the biological concept. It does comply with medical practice, even out of the scope of organ transplantation. We apply this principle of permanency all the time in patients. The term permanent does comply with the medical practice standard to determine death in case of organ donation as well, under the condition of some safeguards. And that's the critical point, because the consequence can be that the patient might be dying because of organ procurement and then violate the dead donor. What are these safeguards in DCD organ donation? Well, the safeguards are that we have to use a validated test to observe or to quantify the absence of blood flow. As pointed out, in most of the times we use surrogate parameters to define that, but that's okay. That's a well-accepted practice. The no-touch interval must exclude autoresuscitation as well. But most importantly, prohibition of medical interventions to restore circulation because of the risk of brainstem function is very crucial and very important. And there we come in a very gray zone when we look at our current practice of normothermic regional perfusion, which means that after declaration of death, we will reinstall circulation in abdominal and or thoracic organs only to preserve these organs in the body before procurement. We have adjusted a lot of safeguards, surgical safeguards, such as excluding the supraaortic vessels by clamping these vessels in order to comply with the dead donor rule. However, this practice has been full of so many assumptions, and there's little research about and reporting about neurological monitoring and also about the potential of collateral circulation. It might seem minimal, but it's very important for us as anesthesiologist professionals because we are dealing with signing of these patients and declaring these patients dead. So these safeguards are really criticized these days, and it's a lot of debate ongoing in this practice. In my opinion, we have been overestimating the need for good organs to save patients, which is a very important principle, of course, but we have been over-addressing this aspect, and by that defining a bit what kind of donors we would need. But we must reinstall the arrow in the other direction, because it's also important to really advocate the donors and see it separately from the need for good organs for patients. And that's the ethical, delicate balance we are dealing with as anesthesiologists in a daily practice. We should be aware that we really are dealing with the principle of non-maleficence in these organ donations and DCD organ procedures. We should respect the donor rule. We give comfort therapy to these patients and should also respect the comfort of the patients. We are actually trained to maintain life and not give comfort in a living patient that is dying. And a lot of transparency is missing about the comfort therapy we are applying to these donors in their dying process. So how should we proceed with these ethical concerns regarding DCD organ donation? In my opinion, we should readdress the role of the public opinion in these discussions. At what point are certain actions acceptable? And we should not forget that public opinion might have different perceptions about death and the concept of death than we think as professionals. We are really focusing on the medical concept, but a lot of societal aspects really should be taken into account. And it can be nicely illustrated by a lot of references and a lot of reports on the perception of that in different groups. And if you read through this literature, what is really important is that the principle of that is important, of course, but that the society is really focused on the futility of care. And the perception of that is less problematic if you are sure about futility of care. We should really invest more in defining when a certain treatment is hopeless and does not fit into the beneficence of the patient as an independent process. And if you explain this to the relatives and address this importance of futility of care, we might even balance more all the aspects, ethical, societal, and medical aspects in defining a donor for organ transplantation. We should invest a lot in the selection process. We have potential donors, but we also should shift to more the concept of candidate donors. Which donors are expected to die within a reasonable time? This might be important to exclude more of the dry runs. We have not invested a lot of time and efforts in trying to select these donors towards candidate donors, and we should be very sure and try to invest more in the knowledge of prognostication and futility of. And then the premortem interventions, we are all missing a lot of transparency. We give sedatives, we give analgetics to provide comfort to these patients. However, it's the real Achilles heel for donor professionals as anesthesiologists, and it's my plea to be more transparent and more supportive to our profession in applying this comfort therapy in this population. Second point of action is that we should not fear redefining our definitions regarding death. Death, as it is today, is more seen as a permanentization of an organism as a whole. And more we see that the definition of the brain, that the definition of the brain function can be a core in defining death. The cessation of brain functions is really reflecting the death of the whole organism. And we should step away from this bifurcation by defining death in two ways. There's only one death. There's only one death, and there's no such thing as a circulatory death or brain death. You all die because of the cessation of your brain function and your organism. This is not exclusively my opinion. We see also that UDDA is under revision and that they are really thinking about this. They are thinking about replacing the time irreversible to permanent to comply with our practices in donor care and DCD organ donation. Also, we have seen a real shift to a more uniform definition of death as defined by brain arrest. This can occur by direct brain injury, respiratory arrest, or circuit arrest, but there's only one state of death, and it's the same death. And this should shift away from the bifurcation of defining death in this population. By taking that into account, we should acknowledge that we should engage in better research, especially regarding this normotermic critical perfusion, and especially about the safeguards and the conditional definition of death in DCD organ donation. Do we really know what are the lower limits of blood flow? Do we really know a lot about the collateral circulation in this population? And in my opinion, we should perform NRP or normothermic radial perfusion more in research protocols and invest much more in knowledge and research about brain perfusion and brain function. This is, I think, a really important aspect to regain and to maintain even the trust from the society in our practices and to support the professionals, anesthesiologists who are dealing with the DCD organ donation practices on a daily basis. This slide summarizes my points. I think we should embrace momentum these days, especially by readdressing the importance of defining that and all the ethical concerns surrounding this, especially with normothermic ritual perfusion. And it's a momentum to rebuild trust with society and within and with medical professions. We should not only focus on waterproof definitions, and we should engage in human observational research, not taking too much assumptions in this. We should support the professions and we should understand our practice and trying to be supportive in the concept of that and supporting the dead donor rule and all the knowledge surrounding that donor rule. We should even invest more in contingency protocols. What should we do when a DCD procedure fails? It should be more transparent. It should be more supportive to our profession. And we should never fear new insights because it has always been the case in history that new insights in defining that are evolving, and that will never be a fixed definition in time. It will always evolve throughout time and throughout time eras. With this, I would like to thank you for attention, and I hope you might have some interesting questions to discuss afterwards. Thank you very much.
Well, thank you very much to all of our speakers. I'd ask them to go ahead and turn on their videos and audio. Welcome everyone to the live question and answer session for this webinar. Please continue to place your questions within the Zoom chat or within the Anesthesiology and Critical Care Professional Community Forum on ISHLT Connect. Before we get started, I'd like to thank our speakers on behalf of our Anesthesiology and Critical Care Professional Community Leadership Council. Our goal was to create a webinar that was international and multidisciplinary, and it's really an added bonus to have speakers who are members and leaders within their respective societies that have such a strong presence within the perioperative transplant space. Looking at the Zoom, the very first question I see is from Professor Markson, and actually from Imperial London. He asked it for Dr. Lindstedt. He asked really two questions. First, he said, you've shown apoptosis data and a dramatic protective effect of cytokine removal therapy. What is the postulated mechanism between the cytokines and apoptosis, and particularly as it relates to the improved recovery that you saw around day 2 in your data?
So that's a really interesting question, how the cytosorb absorption could, improve graft function. So what we think is the mechanism action is actually the activating neutrophils that produce extracellular traps. That might be one part of the mechanism of action, and it would also correlate quite good with PDD at day 2 and day 3. But and it's also if it's good to reduce all cytokines or just some of them, and I mean with this kind of device we reduce all, but it's we do think that it has to do with the activating neutrophils. I don't know if you had two questions. This was the first question, but
that was the first one, and the second was, do you plan to start our clinical trial, or have you started one already?
Yeah, so we did a feasibility trial just with a couple of patients, and then we are setting up a clinical trial to see if we can get the same effect in patients. So there's been quite a lot of studies and also other preclinical studies with some positive results and some negative results, some differences in the different studies, but yeah. Let's see what the when we do a randomized control study, what the effects can be in the clinic.
Excellent. Actually, I have a question for Dr. Bodiger. This is from the chat. Dr. Mosca asks, is the effect of transfusion on graft function independent of the volume effect? And what exactly do you postulate is its mechanism?
Thanks for that question. I think that's a great question. When we look at the retrospective studies that are presented, often or registry trials, it's often co-founded or confounded. So anytime you give more volume, you're giving more product typically. So I don't think that we know how to separate those two in retrospective fashion, but certainly in prospective fashion, it would be interesting to study some of the biomarkers associated with primary graft dysfunction and identify which ones are present in the transfusions. Because there are some inflammatory markers present in just blood transfusions themselves, whether or not those transfusions by way of an immunologic mechanism actually create primary graft dysfunction or influence primary graft dysfunction. And then there's obviously tons of biomarkers for epithelial dysfunction, for endothelial dysfunction of the vasculature that overlap with thromboinflammatory markers of mechanical circulatory support. So it'd be interesting to study the sources and then over different time points, how those biomarkers change. I think that would help us get to the mechanism.
Thanks for that answer. A couple of other questions that came in for you, Dr. Bodiger. The first is this. Do you think that it's a feasible idea to apply preoperative optimization concepts to a lung transplant population, specifically because they require such urgent surgery?
Thanks. Another great question. I think the answer is probably sometimes. In patients that we are able to see them as outpatients, we are able to do a full workup for anemia, for instance. We may find them amenable to some of the therapies that are kind of described in cardiac surgery. My feeling is if we can do it for a Jehovah's Witness or blood refusal patient population for cardiac surgery, that we could do it at least for some or most of our lung transplant population as well. Some patients won't start with anemia, so maybe they aren't amenable to those therapies, but I think it's certainly worth examining in this patient population.
And the follow-up question that came from another colleague, I think, is related to minimizing blood transfusions. We've all perhaps used factor concentrates within our practice, but as we see an increasing use of VA ECMO and ECLS, is it safe to use these factor concentrates in the setting of either impending or ongoing VA ECMO for lung transplant?
So I do think that timing is really important to consider as you're discussing this with your teams and what's available. So things like blood transfusions and cryoprecipitate fresh frozen plasma always is a balanced solution typically. So you'll have both procoagulants and some kind of balance with protein C and protein S, for instance. However, if you're giving shear factor concentrates, those aren't always balanced solutions, and factor 7A is a great example. So making sure that at least the team is aware of what you're about to administer, that what you're looking for in terms of risk, you're examining for potential thrombosis and effects of that. It's just good to have an educated conversation, but I think timing is definitely important.
And one of the things I see from Dr. Brodt in chat is going back to your previous question, she also echoes the importance of having a multidisciplinary prehabilitation program. So I think that's really in line with the spirit of ISHLT and then the contributions that anesthesiologists can have within the perioperative setting. A few questions for Dr. Gilzinis here in chat. Dr. Mosca asks, do you have any experience with bronchial anastomotic ischemia after prolonged use of VA ECMO?
Actually, we don't really see our patients much after. So
The bronch lab is in another hospital, so we don't really see how many people get stents. So I can't tell you the exact number of patients that we see having bronchial anastomosis, but so I can't give you an exact percentage, but it is more like 10 to 20% will come to the interventional suite for stents. And yes, we do have pretty prolonged VA ECMO runs, although they are getting shorter.
And there's quite a few questions about primary graft dysfunction as it relates to ECMO. The first is from Dr. Jaya Simhan. He asked, are there any donor or recipient factors that may predict transplantation that is high risk of primary graft dysfunction who may benefit from prophylactic vena-venous ECMO?
Pulmonary hypertension is the biggest one. And then on the graft, it's EVLP or a marginal donor. Those are all recommendations for prophylactic VA ECMO, VV ECMO after lung transplant.
You know, it's interesting. We talk about a lot of the controversies related to ECLS management. And I know that you mentioned the LORE registry trial. So I'm actually going to direct this to Drs. Bodiger and Nyrink because they were both on the paper. From our reading of it, it seems that off pump is superior to ECMO in terms of attenuation of PGD. However, this runs counter to various proponents of the utilization of elective VA ECMO for primary graft dysfunction reduction. Can both of y'all please comment on those disparities and conclusions within the literature?
Yeah, sure. I can go. No, I'm totally aware of this, and I should first point out, of course, this paper is really, you should be put in context. It's retrospective analysis, it's propensity matching. I think there's always a big kind of bias in this kind of literature by which patient you select to go on ECMO. So it's very unclear to what is the indication to go on ECMO. So most of the time that's in my opinion the biggest bias in all literature, so which is not harmonized, and there are so many differences in protocols among centers that it's very, very difficult to make firm conclusions. And this analysis with Gabe Laura, it was very clear, it was a nice retrospective analysis, registry based. So for this question, I think we and it was also pointed out by Teresa, we need prospective trials with very harmonized protocols that are very comparable between centers. I see so many differences in practices that it's sometimes very difficult to make these conclusions.
Can I also say that a lot of, when you actually look at the patients who are off pump, a lot of them were COPD patients with low PA pressures. So those are patients who are going to do well regardless of whatever you do to them. And it's easy to do an off pump with those kind of patients.
Yeah, and that's also the bias in the literature, I think. So, and as you pointed out correctly, it's mainly the PH patients and the marginal and EVLP donors that need more attention for ECMO. So that's,
and the interstitial lung disease patients with the graft, the size discrepancy with their chests and the grafts.
Yeah. So in my opinion, it's always very difficult to make this. We have these discussions on a daily basis in our center as well, and I think everybody recognizes these discussions. What is the impact of ECMO on the outcome, and should we go on ECMO or not on ECMO? It's a lot of back and forward, I think. So if something would come out of this meeting, I think harmonizing and doing it in a prospective way might be a much better approach than in a multi-center setting. It's a small group to study in one center, so it should be solved in a prospective way, I think.
And the thing is too, is that second one from our institution had the same exact outcomes. Yep. And it's interesting because our surgeon, when he first came, liked to do a lot of cases on pump, and now even he is moving more towards VA ECMO. So at least it's doing something.
I think the other thing that lacks, you mentioned the selection bias, the registry data also blended VV ECMO and VA ECMO in one group. The other thing that it lacks is really the decision-making that you pointed out, but also conversions. So the patients that started out off pump and had to crash onto a higher level of support. And that's the same in the VA ECMO who had to convert to bypass. So that's an important thing to remember when you're reading some of these things.
Yeah.
One of the points, just hearing Arnie bring this up, is that there is significant practice between centers, and any prospective trial needs to have that harmonized. You know, I think about the data that have come out of Foch Hospital with Dr. Julian Fessler, Professor Fischler, who use predictors for how patients are going to do with an ERAS or a rapid recovery protocol intraoperatively. So there could be some specialization, particularly with regards to etiology of end-stage lung disease, touching base on what Dr. Galzina said. I think there's another aspect, though, and this came up, Dr. McCartney actually brought it up in the chat. When we're utilizing ECMO, we're starting to use massive amounts of volume as compared to an off-pump approach. And yet it appears that the PGD seems to be relatively similar or even less in some studies. So I think this is really a question for the entire panel. How do you evaluate the fact that we're giving all this fluid and yet we're seeing some improvements in primary graft dysfunction within VA ECMO? So I throw that out to the entire panel.
Well, VA ECMO is still associated with less blood. And so you're taking that out of the equation. I mean, in a lot of our VA ECMO patients, we're not giving them any blood transfusion. So it could be the difference of not getting any kind of blood products on their effect on PGD versus, and we don't really give that much more volume in our ECMO patients than we would give in our non-support patients, especially when we lost albumin, because we used to give more albumin and less volume to our patients. But we'll see if that changes now that we don't have it anymore.
I'll also comment, I mean, I do think for better or for worse with our transition to VA ECMO, Sharon's pointing out that we do give more volume than we used to, but we used to also have a very volume restrictive type of policy and protocol. Where once we went beyond, I think, 2 liters of crystalloid, we would, based on, experience versus any actual published data, that we would go towards transfusion. And we'd use a lot more pressors and inotropes. So I think to Sharon's point, we are giving more volume, but we're seeing a reduction in other kinds of end organ dysfunction like AKI. So I think the truth is probably, or the best is probably somewhere in between in terms of volume and inotropy and getting it right. But there's certainly a correlation between, I think, malperfusion, either on ECMO or off, and end organ dysfunction that we could probably pretty clearly see. Ooh, Julian Fessler commented.
We're running out of time, so I just want to provide a question that came up to Arnie. As we're doing these ethical considerations, particularly in DCD programs, how do you select your candidate and potential donors to ensure a maximal success with limited dry runs?
I think the key of success in our experience is to do it multidisciplinary. So we don't separate the ICU care people with the anesthesiologists who do the switch off. We really go bedside and have a look at the patient, and we try to assess the level of support that is in that patient present. So we tend to use the UW score, prediction score, for extubation, but it seems to work very, very poorly in our experience. So we have developed our own criteria, which are not published yet, but we have severe and minor criteria. And so there must be a level of support to maintain vital functions. And the key of success in our experience is to start comfort therapy very early on. So do not wait until you switch off the patient to start your comfort therapy. That's what you not do with any DNR code. So you always start comfort therapy in time, which as a second effect probably depresses a bit the respiration, but it's acceptable. It's because of the comfort, that's the target. And always extubate your patient. I think extubation is really key of success. But really go bedside and organize a team that is really responsible for the selection of these patients, because you learn a lot by doing it and by experience. So we don't let everybody do it. So we really focus the expertise and really have some rounds and debriefings after each donor to learn from the criteria.
Excellent, thank you. So as we wrap things up, I'd like to take the opportunity to thank our audience. We've had over 200 registrations from multiple states, countries, and continents, and we appreciate the time that you've spent with us today. No matter what your role is within the multidisciplinary transplantation team, You can be part of a growing community of professionals who are dedicated to working together toward a brighter future for our patients. If you'd like to learn more about the International Society for Heart and Lung Transplantation, please visit us at ishltv.org. Thank you.